Hello, this lecture is about puerperium, which is defined as the time following the delivery during which pregnancy induced maternal and physiological changes occur, and these changes return to their non pregnant state. The duration is about 6 weeks, and the duration is divided into three parts: immediate puerperium, early puerperium, and remote puerperium. So, the period just after delivery up to 24 hours is immediate puerperium. Early puerperium is up to 7 days or 1 week, and from 1 week onwards till 6 weeks, it is remote puerperium. Now there is concept of fourth trimester. This puerperium is also known as the fourth trimester. The concept of fourth trimester was given by ACOG in 2018, and this concept reinforces the importance of 12 weeks after birth. That is, 12-week period after delivery is considered as fourth trimester. And the components of this model are as follows: the care team, the postpartum visits, lactational support, infant feeding plan, reproductive life plan, contraception, pregnancy complication, cardiovascular risk assessment, mental health, postpartum problems, and chronic conditions. So, what are the concerns raised by a woman in the puerperium or the puerperial period? The concerns can be the pain after cesarean delivery, which is the most common, feeling stressed in 54% of the cases, breastfeeding issues, perineal pain after vaginal delivery due to episiotomy stitches, need for social support, inadequate education about newborn care, help with postpartum depression, perceived need for extended hospital stay, and need for maternal insurance coverage postpartum. Now there are some anatomical changes that occur in women's body. What are these? First, we will discuss the changes that occur in the uterus. So soon after delivery, the soon after the delivery of placenta, the fundus of uterus lies at the level of umbilicus. Involution of uterus occurs in the puerperial period, and the fundal height is getting decreased by 1 centimeter per day. So 1 centimeter per day is the reduction or the involution rate that is happening in the uterus. So just after delivery, the uterus lies at the level of umbilicus, and it is 1000 grams or 1 kg in size. After 1 week, the size of the uterus involutes and the weight becomes 500 grams. Then after 2 weeks, the weight is 300 grams and uterus is not palpable per abdominally after 2 weeks. So this is a question: after how many weeks the uterus becomes a non-palpable organ? It is after 2 weeks of delivery. So how do we monitor the uterine involution and decline in the uterine volume? It is measured by ultrasonography, and by ultrasonography we can see that the uterus and the endometrium. So endometrium returns to pre-gravid size by 8 weeks postpartum, or around 2 months. So this is a uterine volume in centimeter cube, and these are the weeks of delivery. So after 8 weeks, the uterus returns to its pre-gravid size. Now coming to the changes in the birth canal or the cervix, the vagina and its outlet gradually diminish in size, but they rarely regain their nulliparous state. So there is a clear difference between a nulliparous woman and a woman who has recently delivered. The rugae begins to appear in the vagina by 3rd week but are less prominent. So after how many weeks the vaginal rugae reappear? They reappear by 3rd week of delivery. The hymen is represented by several small tacks of tissue which scar to form the multiform caruncles. So this is the cervix of a nulliparous female and a parous female. So in a nulliparous female, the cervix is pinpoint, while in parous women the cervix is slit-like, or there is transverse slit on the cervical os. Now what are the decidual and the endometrial changes? The decidual differentiates into 2 layers. Initially the endometrium, the superficial endometrium becomes a decidua during pregnancy, and after pregnancy this decidual layer is divided into 2 parts, that is the superficial layer and the basal layer. Superficial layer becomes necrotic and sloughs off and is expelled with the lochia. So here the menstrual blood is not the terminology that we use the terminology lochia. While the basal layer, just like in menses, it remains intact and it will form the new endometrium. Entire surface is covered by new endometrium within a week. So what will happen to the HCG levels? After the delivery of the baby, HCG levels completely eliminates between 8 to 24 days. Means it takes around 1 month to become to make the HCG levels in a pre-pregnant state. And the hot flashes can also be a complaint of the patient after delivery. The cause is unknown, but the cause can be due to thermoregulatory dysfunction due to estrogen withdrawal, which can cause hot flashes. And the resumption of ovulation begins by around 2 to 3 weeks. So gonadotropin and sex steroids are at low levels for 2 to 3 weeks, and by 12 weeks postpartum, in around 70% of the women they menstruates. While if the women is breastfeeding exclusively, then only in 40% of the patient can present with amenorrhea for around 6 months. So what is the mechanism of amenorrhea and anovulation in lactating mothers? So when a breastfeeding women so when a mother breastfeeds, what happens? There is increased serum prolactin levels in these women, and the level is more than 50 nanograms per ml. The breastfeeding, the method of breastfeeding, like the suckling frequency, if the suckling frequency is around more than 28 per hours, if there is high intensity and the duration is more, so the serum prolactin level can be as high as more than 50 nanogram per ml. What this prolactin does, that it decreases the estrogen and progesterone levels. So the prolactin inhibits ovarian response to FSH, and there is less follicular growth, so there is a hypoestrogenic state which causes no menstruation. Also, there is suppression in the release of LH, and this LH does not rises, and hence there is no LH surge. So when there is no LH surge, what happens? There is anovulation. So there is no menstruation, anovulation, and this high prolactin also causes suppression of GnRH secretion. This GnRH is released from hypothalamus. So all hormones are reduced, and if the increased frequency, intensity and duration of suckling is there, there is high prolactin level and prolonged ovarian suppression and lactational amenorrhea. So this is the basis of lactational amenorrhea in a postpartum female. Now, what are the clinical aspects? We have seen that for the sloughing of decidua, there is release of some discharge known as lochia, and this is a vaginal discharge of variable quantity. Now this lochia contains blood cells, that is erythrocytes, shredded decidua, epithelial cells and the bacteria. This lochia is divided into three parts: lochia rubra, lochia serosa and lochia alba. The names differ based on the presentation, the color of the discharge and the duration. So for the initial first week, that is in the first 4 to 5 days, there is a release of lochia rubra. In 5 to 9 days, lochia serosa is released, while in after 10 days of delivery, lochia alba, which is white in color, is released. The average duration is around 24 to 36 days or around 1 month. So this secretion takes 1 month to disappear. So these are the differences between lochia rubra, lochia serosa and the lochia alba. Total amount of lochia that is released after delivery is around 200 to 500 ml. What is lochia rubra? As the name suggests, rubra is red. So this discharge is coming till initial 5 days after birth, and it is bright red or dark red in color. It may have the clots, and the flow is similar to heavy menstrual blood flow. Up to 15% patients of lochia continues 6 to 8 weeks postpartum. So in 85% of the patients, this lochia disappears by 1 month, but there are certain patients, in about 15% of the patient, this can continue till 6 to 8 weeks, means around 2 months. Now what is lochia serosa? Serosa is pinkish to brown colored discharge from the vagina, and it is for about 5 to 9 days. The flow is moderate to small in amount, and the lochia alba, which is white or yellow in color, as the name suggests, alba is white. It is released after 10 days of delivery, and it gradually reduces and then disappears. Now there is one condition that occurs in postpartum patient, which is after pains. So in these after pains occur in 50% of the patient, and here what happens, there is intermittent contraction of the uterus. So the patient feel this as after pains or pains which is similar to the labor pains, but the intensity is mild. They are more pronounced as the parity increases and worsen when the newborn suckles because of oxytocin release. So what does oxytocin do? Oxytocin receptors are present on the uterus, and when the newborn suckles the breast milk, there is release of oxytocin from the maternal pituitary, and this oxytocin acts on the uterus and causes contractions, and hence when the parity is more, the contractions are more, means after pains are more. These after pains becomes mild after third day of delivery, and if these after pains are severe and persistent, then postpartum uterine infections are suspected and they have to be ruled out. Now, the placenta site always involutes, as we know, and the complete extrusion of placental site takes around 6 weeks. So, this complete postpartum period is the period of placental site involution. This site is weak because the placenta is attached there, and immediately after delivery, placental site is approximately a palm size. But at the end of second week, means just after 2 weeks, that when the uterus becomes a non-palpable organ, it just measures to 3 to 4 centimeters. This is an exfoliation process, downward growth of the endometrium from margin of the placenta side, and upward development of the endometrial tissue from the glands in the stroma left deep into the residua basalis. So, what is involution? It results because of incomplete remodeling of the spiral arterioles and retained product of conception or infection. So, involution is good, but why? But why subinvolution is bad? Because it is a process where the uterus is not going down or not getting decreased in size, and this subinvolution is because of incomplete remodeling of the spiral arterioles, or if there is RPOCs or retained products of conception, or if there is puerperial infections. What are the clinical features? Patient can present with irregular or excessive vaginal bleeding. Why? Because RPOCs tends to cause the bleeding, and infection also alter the endometrium in the uterus. So what are the findings on bimanual examination? So when we do the perispeculum examination, we can see a discharge or increased blood loss, and on bimanual examination, because there is subinvolution, so the expected uterine size is not there, means the uterus is larger and softer. On USGs, RPOCs are seen as thickened endometrium and endometrial mass or increased vascularity is there, and subinvolution is characterized as enlarged uterus with tubular hypoecheic area in the myometrium, and these tubular structure reflects neovascularization and the dilated uterine vessels. So, one third of the cases of late endometritis or postpartum metritis are caused by chlamydia trachomatis. So, one third of the late cases are caused by chlamydia trachomatis, and the empirical therapy for chlamydia is either doxycycline or azithromycin. So, either we can give a combination of doxy and metron, but because doxy is contraindicated in a breastfeeding female, so we can advise them with azithromycin and cefixime and metron for proper coverage of gram-negative, gram-positive and the anaerobic bacteria. So in this USG image, can you see a vascularity, and there is collection of some product of conception. So this is RPOCs with vascularity, and here the endometrial thickness is increased with collection. So these images suggest RPOCs or uterine subinvolution. Now what happens, what changes occurred in the uterine tract just after delivery? So normal pre-pregnancy glomerular hypofiltration persists in puerperium but returns to normal by 2 weeks. So 2 weeks are taken for restoring the glomerular hyperfiltration. Dilated ureters and renal pelvis returns to their pre-pregnancy state by 2 to 8 weeks, and this dilatation occurs because of progesterone hormone. Postpartum, the bladder has a greater capacity and a relative insensitivity to intravesical pressure. As a consequence of overdistension, incomplete emptying and excessive residual urine are frequent. Because of this dilated collecting system, the residual urine in the urinary tract is a concern in puerperium because it can lead to urinary tract infections. So what happens to the peritoneum and the abdominal wall? The abdominal wall remains soft and flaccid. Because of distension by the gravid uterus, the elastic fibers and the muscles are flaccid and soft. And after LSCS, 6 weeks are required to allow the anterior abdominal wall fascia to heal. So it takes around 1.5 months after LSCS for proper healing. And the marked separation of the rectus abdominis muscle, known as diastasis recti, may result. It results because of the thinning and widening of the linea alba and the laxity of the ventral abdominal wall muscles. So what are the changes that occurs in the blood and the blood volume? So there are some hematological and the coagulation changes. There is marked leukocytosis, means TLC is raised. There is thrombocytosis, platelet levels are also raised and may occur during and after labor. There is lymphopenia, so the lymphocytes are less, TLC is raised, platelets are raised, eosinophils are reduced. So there are two cells which are decreased, lymphopenia and eosinopenia. During the first few postpartum days, the hemoglobin and hematocrit also decreases moderately. And why it happens? Because of the blood loss during delivery, there is reduction in the hemoglobin and the hematocrit level. By the end of pregnancy, coagulation cascade is altered and high fibrinogen level is maintained at least through the first week. And why this happens? So as to prevent the excessive blood loss after delivery also. So as a result, the chances of deep vein thrombosis persist in the puerperium because of high fibrinogen level, and the patient is in resting stage. So there is increased chances of deep venous thrombosis in the puerperial period. Now, what is pregnancy-induced hypervolemia? So, as we know that the blood volume is increased in pregnancy, so the plasma volume increases by 50%, while the RBC volume increases just by 20%, and hence there is hemodilution, and the blood volume generally returns to its non-pregnant state by 1 week after delivery. So, it takes 1 week to make the blood volume in a non-pregnant level. Cardiac output usually remains elevated for the first 24 to 48 hours postpartum and decline to non-pregnant level by 1 week or 10 days. Systemic vascular resistance means the vasoconstriction or vasodilatation remains in the lower range for 2 days postpartum and then begins to rise after that. So because the cardiac output is elevated, hence the patient is prone for congestive heart failure in the puerperial period. Now, what is postpartum diuresis? Normal pregnancy is associated with sodium and water retention, and this sodium is leading to increase in intravascular volume. And what happens in postpartum period? There is postpartum diuresis, which is a physiological reversal. So, this postpartum diuresis means increase in urine production after delivery results in relatively rapid weight loss of around 2 to 3 kilograms, which is additive to 5 to 6 kilograms weight loss with delivery of the fetus, placenta and the amniotic membrane. So as we know that there is a weight gain in pregnancy, and just after delivery the weight of the mother is reduced. First cause of reduction in weight loss is delivery of the fetus. Then there is 500 grams of placenta, amniotic membrane, amniotic fluid is there, and also due to postpartum diuresis there is reduction in weight loss of around 2 to 3 kilograms. Now, what are the neuromuscular problems that can occur? So, obstetric neuropathies, which can be due to the pressure on the lumbosacral nerve plexus. So, during labor, due to intense neuralgia and the cramping pain, this lumbosacral nerve plexus can become compressed, and it can lead to pain down in both or one leg as soon as the head descends into the pelvis. So, there is pain in either one or both the legs due to this lumbosacral nerve plexus. Also, there is one nerve which gets injured during normal delivery. What is this? This is LCN, or the lateral cutaneous nerve of thigh. So this LCN neuropathy is the most common, and it occurs in 24% of the normal vaginal deliveries. And what is the presentation after this neuropathy? So the patient can present with paresthesias, that is lateral hip pain accompanied by burning pain. Hypoesthesia means numbing or tingling over the upper outer thigh, and there can be other neuropathies also like peroneal, femoral and obturator. So this lateral femoral cutaneous nerve supplies the lateral aspect of the thigh and the limb, and burning pain, numbness, tingling can occur in the outer thigh. Now, what are the risk factors where we can suspect this nerve injury? So if the baby is larger, means fetal macrosomia, so the delivery will be difficult. In malpresentations like breech delivery, and in prolonged lithotomy positions also causes nerve injuries. Extremes of maternal weight. So if the maternal weight is very less, means she is very underweight and there is a normal delivery occurring, or if the patient is obese, so these are the risk factors for postpartum nerve injury. Prolonged second stage of labor is also a risk factor. So what are the common nerves which gets injured during cesarean section? So this can be ilioinguinal nerve and iliohypogastric nerve. So what happens when we give incision of the cesarean section? So there is presence of nerves on the lateral aspect of the C-section. So at the angles, these two nerves crosses the inferior epigastric artery. So if we extend that incision of, or if the incision is given big, then these nerves can be entrapped while stitching the rectus muscle, or can be injured during extension of the cesarean section. So what are these nerves? These are iliohypogastric nerve and the ilioinguinal nerve. So this is the diagram. These are the inferior epigastric vessels, and when we give the incision or a phalansteal incision, these iliohypogastric and ilioinguinal nerve can be injured. Now what are the musculoskeletal injuries that can happen? So patient can present with pain in the pelvic girdle, hips, lower extremities, which usually resolve with anti-inflammatory agents and the physical therapy. If there is separation of pubic symphysis, also known as symphysis pubis diastasis, or one of the sacroiliac synchondrosis during labor, it can lead to pain and marked interference with locomotion, and the normal distance between symphysial joint is 0.4 to 0.5 centimeter. Symphysial separation more than 1 centimeter is diagnostic of diastasis. So in this patient, you can see on the X-ray that the symphysis pubis is the distance between the both side pubic symphysis is increased, and it is more than 4 centimeters, and hence it requires a surgical treatment. So the treatment is conservative if the distance is less. In lateral decubitus position and appropriate pelvic binders are given, and symphysial separation more than 4 centimeters requires surgical management. Recurrence risk is high in subsequent pregnancy, and these patients are to be considered for cesarean section if they conceive again. So this is pubic symphysis diastasis, where there is separation between the two pubic symphysis joint. Now coming to the management of normal puerperium. So the principle of management is to restore the health of the mother, to prevent the infections, to take care of the breast, including breastfeeding promotion, and to motivate the mother for contraception. So what we have to see, we have to restore the health of the mother, infection prevention, breastfeeding, and to guide for contraception. What are the components of management of a normal puerperium? We have to do maternal monitoring, early ambulation, diet and nutrition, perineal care, care for bladder and bowel, pain, mood and cognition, care of the breast and breastfeeding, and care of the neonate, and contraception. So for maternal monitoring, just after delivery, we have to take the blood pressure and the pulse of the patient at every 15 minutes for the first 2 hours. So for first 2 hours, we will take her vitals every 15 minutes. For the first 8 hours, the temperature recording is done every 4 hours, and at least every 8 hours subsequently. After delivery, mother should be closely monitored in the labor room for at least 2 hours, and the risk of hemorrhage is greatest immediately postpartum, so the vaginal bleeding is closely monitored. Now coming to early ambulation, patient should be told for early ambulation, and it should be done within a few hours after vaginal delivery and after 6 hours following a cesarean section. And what does early ambulation do? It reduces the bowel and bladder complications and reduces the risk of postpartum venous thromboembolism. The mother and the child can be discharged. After normal vaginal delivery, we can discharge the mother after 48 hours, that is for 2 days, and after cesarean section, we can discharge her after 3 days or after 72 hours. Now, how do we prevent the venous thrombosis? The thromboembolic events are the leading cause of direct maternal mortality worldwide. So these thromboembolic events are more common during pregnancy and the postpartum period, and because of late ambulation, they can be seen just after the cesarean section. So according to ACOG, low risk patients should be encouraged early ambulation as soon as 8 hours post-op. So we can tell them to ambulate early as soon as 8 hours post-op. While high-risk patient, we have to give them both mechanical and pharmacological therapy. So in what patients do you advise the pharmacological therapy for venous thromboembolism prevention? The criteria include if the patient is having history of venous thromboembolism, Any thrombophilia, either inherited or acquired. If her BMI is more than 35, then we have to give her pharmacological therapy. Or the other prominent risk factors like autoimmune disease, heart disease, sickle cell disease, multiple gestation, or preeclampsia. So in twin pregnancy, preeclampsia patient, heart disease patient, autoimmune disease and sickle cell disease, we advise pharmacological therapy. And in pharmacological therapy, we have to give 6 to 12 hours after cesarean section. So this is given 6 to 12 hours after cesarean section. So the pharmacological therapy includes low molecular weight heparins, and the low molecular weight heparin that we give is either enoxaparin, dalteparin, naraparin. So what is the dose of enoxaparin? If the weight is less than 100 kilograms, the dose is 40 milligrams subcutaneously once a day. And if the weight is more, that weight of the female is more than 100 kilograms, then enoxaparin in a dose of 60 milligrams subcutaneous injection once a day is given. So this is the pharmacoprophylaxis for venous thromboembolism. Patient who requires prolonged anticoagulation, oral warfarin can be given, and if there is history of venous thromboembolism, then this thromboprophylaxis can be given for 6 weeks postpartum. Ambulation after cesarean section, 5 to 10 minutes, 4 times a day, 4 hours after cesarean section. So we ambulate the patient after 4 hours of cesarean delivery, and we tell her to stand or walk for at least 5 to 10 minutes at least 4 times a day. So this is the criteria. Now what is this? What is this device called as? This is intermittent pneumatic compression device, and this is the mechanical therapy if the criteria is fulfilled or in high risk patients. So this is intermittent pneumatic compression device. This prevents DVT by enhancing the blood flow in the deep veins of the legs and thereby preventing venous stresses. So this IPC device reduces PAI. PAI is plasminogen activator inhibitor 1, and thereby increasing the endogenous fibrinolytic activity. Now what do you advise in diet and supplements? So after 2 hours of uncomplicated vaginal delivery, a woman is allowed to. So we tell the patient to have meal after 2 hours of uncomplicated vaginal delivery, a balanced diet, that is 30 calorie per kg ideal body weight with extra 500 calories for lactation is recommended, and the iron supplementation should be continued for around 180 days or 3 months, along with calcium supplementation as long as the patient continues breastfeeding. So early food intake is advised after cesarean section. Usually we advise the patient to take oral sips after 6 hours of cesarean section, but it can be recommended after 2 hours also, because it enhances the return of bowel function by stimulating the gastrocolic reflex. Chewing gum thrice a day for 15 minutes enhances post-operative gastrointestinal recovery. So these are the recommendation for the intake of fat soluble vitamins, water soluble vitamins, minerals and protein, carbohydrate and fibers in a pregnant and a lactating women. So what is perineal care? Just after the delivery, to reduce the edema and the discomfort, cool pack can be applied to the perineum, and it can be applied for first 24 hours, and we have to clean the vulva, and the cleaning should be done from anterior to posterior towards the anus, so as to avoid the bacteria from the perianal region contaminating the vulva. So it should be done from upwards to downwards direction. Severe perineal, vaginal, rectal pain always needs careful inspection because it can be a hematoma. Sitz bath is recommended because it can reduce the local discomfort, and episiotomy incision normally heals by 3rd week. So it takes around 1 month for the episiotomy incision or episiotomy site to heal. What are the common concerns related to perineal care in our postpartum females? So this is the fear of suture removal. So we have to advise them that the suture is absorbable and it does not need removal. Fear of bowel movement, fear of sexual activity and fear of vaginal discharge. So this is a procedure explained. What is this procedure? Where we first have to clean the tub, then we have to fill it with the warm water, and then we have to add around 1/4 cup of Epsom salt, and then we have to sit in the tub, and after sitting for around 5 minutes, we have to pat dry with a soft towel. So what is this procedure known as? This is a sitz bath. So each episode of sitz bath should be for around 5 minutes in duration, and it should be done at least 4 times a day. Or we can do it after just having a bowel movement. There are conflicting data on the optimal water temperature, but it should be done for 5 minutes and 4 times a day. So, a recent study conducted in November 2022 in India on episiotomy and modalities for pain relief, which said that infrared lamp therapy is better than sitz bath, and it is more effective method. So, what does this infrared lamp therapy do? So, after 1 to 2 minutes of application, there is histamine release, and this histamine release causes cutaneous vasodilation. So, there is increased blood flow in the perineal area, and this infrared lamp has to be placed at a distance of 45 centimeter from the perineum, and the heat is produced at 230 volts for 10 minutes. What are the other uses of this infrared lamp therapy? This lamp therapy can be used for psoriasis, diabetic foot ulcers, and the healing of burns. Now for bladder bowel care, urinary retention and bladder over distension is common in early puerperium period, and the incidence is around 10 to 15%. Risk factor includes the primary gravida female, if there is history of epidural analgesia, cesarean section, if there is perineal laceration, operative vaginal delivery, or prolonged second stage of labor. And if this female has not passed urine within 4 hours after delivery. So a threshold period of 4 hours is taken after delivery. So if in these 4 hours the female has not passed urine, so what do we do? So first we have to examine the perineal area and the genital tract. And why we are exploring this? Because this could be a hematoma which is causing a distension, and it is compressing over the urethra, or because of pain patient is not able to urinate. So after ruling out the local causes, a catheter should be placed for 24 hours, and after placing the catheter for 24 hours, and if there is no passage of urine after 4 hours of catheter removal, after these 24 hours have passed, then urine volumes are measured sonographically. तो अगर 4 आवर्स में पेशेंट ने यूरिन पास नहीं करा है तो हम उसको एक कैथेटर लगाएंगे 24 आवर्स के लिए. 24 आवर्स के बाद में हम देखते हैं कि पेशेंट का कैथेटर रिमूव करते हैं, फिर उसके 4 आवर्स के बाद में फिर देखते हैं पेशेंट ने यूरिन पास करा है या नहीं करा है. एंड इफ द पेशेंट इज़ नॉट पासिंग यूरिन, देन व्हाट डू? वी मेजर हर यूरिन वॉल्यूम्स थ्रू USG. And if in the bladder the urine volume is more, means it is more than 200 ml, then this means that urine production is normal, but the bladder is not working, means it is not getting contracted so as to expel the urine from its outlet. So the problem lies in the bladder. So the catheter is replaced, and it is replaced for another 24 hours. And if on ultrasonography, if the urine volume is reduced, means the problem is in the kidneys, not in the bladder, and now we can remove the catheter. And we have to treat that problem. So in 40% of such women, these women develops bacteriuria. So in these women, we give either a single dose or a short course of antimicrobial therapy. Now, what is persistent postpartum urinary retention? So, if the patient is unable to void urine spontaneously despite the use of an indwelling catheter for 3 days. So, for 72 hours, we have placed a urinary catheter, but and after removal, still the patient is not able to pass urine, then this is known as persistent postpartum urinary retention. And in these cases, we have to keep the catheter in situ for around 3 to 4 weeks or 1 month for complete bladder recovery. Now, what is the most common problem that occurs in postpartum period? It is stress urinary incontinence because of the episiotomy stitches or weakness of the pelvic floor muscles. Now, due to progesterone hormone, the patients can present with constipation either during pregnancy or the postpartum period, and it is occurring due to smooth muscle relaxation due to progesterone and the other hormones. Postpartum, this effect may continue for days to weeks, and pre-pregnancy antenatal bowel habits to be reviewed first, and if there is no underlying GI abnormality, then patient can be advised oral bulk forming agent laxatives like psyllium husk or isabgol, and then progress stepwise until the patient passes soft bowel movement every 2 to 3 days. So what is the protocol? Stepwise treatment plan is given for constipation. Initially we advise bulk forming laxative, like you can see in this image. This is psyllium husk or isabgol. Then surfactants are advised. Then osmotic agents can be given, like coles docusate sulfate, and this is a stool softener, and this is stimulant free. This comes under a packet which is 100 milligram tablet. And then if osmotic agents are also not working, then we can advise stimulant laxatives like dulcolex or the bisacodal. So we allow 2 to 3 days to determine if a treatment is effective or if the next agent is listed needs to be added. So what is the management of pain, mood and cognition? So during the first few days after vaginal delivery, mother may feel uncomfortable because of episiotomy, after pains, lacerations. So for these painful conditions, we can advise analgesics like paracetamol or ibuprofen, and these tablets have to be given for every 4 hours, means 4 times a day for the first few days, and then we titrate the dose according to the pain. Now there is one condition known as postpartum blues, which carries the mild symptoms, and it is self-limiting to 2 to 3 days and may last up to 10 days. And these postpartum blues can occur due to discomfort, fatigue from sleep deprivation, anxiety over the ability to provide appropriate care, and body image concerns. Now what is the management of these postpartum blues? We have to recognize them early and reassure the patient, and if the symptoms worsen, then reevaluation is done for major depression. So these postpartum depressive episodes can be divided into 3 parts: postpartum blues, postpartum psychosis and postpartum depression. The majority of the cases are of postpartum blues, that is 30 to 75% cases, while postpartum depression is around 10%, while psychosis is seen in around 0.1 to 0.2%. So the postpartum blues, the onset is about 3 to 4 days, and it lasts for hours to days, and there is no treatment needed, only counseling is sufficient, and the counseling is done both for the patient and the family members. Now for postpartum psychosis, it takes around 2 weeks, means when the uterus is involuted. So after the uterus is involuted, this postpartum psychosis can start, and it can last from weeks to months, and for this psychosis, hospitalization and immediate treatment is needed. For postpartum depression, it occurs within first month and can last for a year, and the duration can be from weeks to months, and the treatment is mandatory for the last 2 conditions, that is psychosis and depression. Now coming to breastfeeding for the first 2 days after delivery, no further anatomical changes occurs in the breast. Colostrum is expressed from the nipples by the second postpartum day. So initial first and second day is the time period for colostrum secretion, and the first hour is very important because here the breast milk or the colostrum is secreted, which contains IgA antibodies and prevent the neonate from infections, is released from the maternal breast. Now colostrum can be secreted from 5 to 14 days and converts into mature milk by 4 to 6 weeks. So this is the content or percentage composition of colostrum and the breast milk. So the colostrum contains KFC in less amount. What is K? K is potassium, F is fat, and C is carbohydrate. So fat, carbohydrate and potassium are less in case of colostrum, while protein is more. So colostrum contains high amount of protein, while breast milk contains lesser amount of proteins, and the water content is around 86%, 86 to 87%. Now what is the daily secretion of milk by lactating mother? It is around 600 ml per day. Coming to physiology of lactation, the lactation is divided into 4 phases, that is mammogenesis, lactogenesis, galactokinase, galactopoiesis. So what is mammogenesis? Mammogenesis is the preparation of the breast, while lactogenesis is the synthesis and secretion of milk from the breast alveoli. Ejection of milk is known as galactokinesis, and maintenance of lactation is called as galactopoiesis. So here the signal is sent from the cerebral cortex, and this signal is catched by the hypothalamus, which sends the signals to the pituitary gland, and the pituitary gland, mainly the posterior pituitary, releases oxytocin, and the prolactin is released from the anterior pituitary. This prolactin acts on the mammary glands, and the mammary glands forms the milk, while oxytocin, which is a ejection hormone, what this causes, this increases the contraction of the nipples and the breast alveoli, and this whenever the neonate suckles, there is release of oxytocin, and this is the cause of infant mother bonding. So these reflexes, so the afferent is through spinal cord T4, T5, T6, and this oxytocin in spite of this oxytocin also does involution of the uterus through contractions, and also increases the GI hormones and the GI motility. So this is the physiology of breast milk secretion. Now for the care of the breast, the nipple should be washed with sterile water before and after breastfeeding, and if the nipples are fissured, then this can lead to painful lactation. So an emollient known as a lanolin topical emollient coming in the form of nip care 20 grams is applied to the fissured nipple, and these fissured nipples can also act as a portal of entry for pyogenic bacteria. Now, breast engorgement common in women who do not breastfeed. Symptoms are mild milk leakage, breast pain, and it peaks after 3 to 5 days after delivery. So usually it's spontaneously resolved, and if it is increasing, then we have to provide the supportive care like warm compressors or warm showers before feeding to enhance letdown and facilitate milk removal. So it is recommended treatment in women who are not breastfeeding, and use of tight brazier suppresses lactation in 60 to 70% of individuals. So we have to advise to wear the tight braziers, or we have to tell them to use the warm compressors, or warm showers can be taken, or we have to tell them to remove the blood breast milk, or express the breast milk and then discard it. So what are the other lactational issues that can occur? So this can be inverted nipple, lactiferous ducts are open into a depression at the center of the areola. Breastfeeding is difficult because nipple is not everted, and the breast pump here is advised. Now what is polymastia? Polymastia is when the nipples are more than 2, and the incidence is seen in around 0.22 to 6% of the cases, and if these polymastia patients their breasts are getting enlarged during puerperium, this can lead to discomfort and anxiety. Now what is galactocele? Galactocele occurs if the milk ducts are obstructed by the constipated secretions and forms a fluctuant mass that can cause the pressure symptoms, and it may resolve spontaneously. And if the infection is occurring in the galactocele, then we have to aspirate, or we have to do drainage of the secretion. So if there is a mother whose baby has died, means there is history of intrauterine death or stillbirth, and the breast milk is getting secreted in very large amount, that is causing breast engorgement, then what do we have to advise? We have to advise a breast milk suppressant, also known as cabergoline or bromocriptine. So cabergoline is preferred if the breast milk suppression is required after stillbirth. So either we can give a single dose of 1 milligram cabergoline in the first 24 hours after fetus expulsion. So in the first 24 hours or in the initial first day, we have to give single dose 1 milligram cabergoline, or cabergoline, because this is a dopamine agonist, so this can cause extrapyramidal side effects, this cabergoline. So what we advise, we can do this in a titrated dose, means just single dose of 1 gram is not given. We prefer tap cabergoline 0.25 milligrams BD for 2 days. Now what are the contraindication of this cabergoline? The contraindications include a hypertensive patient, cardiac or hepatic disease. And if these contraindications are there and cabergoline is not cabergoline is recommended, contraindicated, then what else we can advise? We can give pyridoxine 200 milligram TDS for 7 days. Now for contraception, family planning education should be given during hospital stay. Women who become sexually active during puerperium and who do not desire to conceive should initiate contraception. The immediate postpartum is an ideal time for consideration of long-acting reversible contraceptive, also known as LARC. So women not breastfeeding, their menses returns by around 6 weeks. and ovulation started 5 to 11 weeks, while lactating women may menstruate as early as second or as late as 18th month after delivery. Breastfeeding episodes lasting 15 minutes 7 times daily delay ovulation resumption. So the duration of breastfeeding needed for lactational amenorrhea is around 15 minutes, each episode lasting for around 15 minutes and at least 8 more than 8 times in 24 hours. So for breastfeeding women, progestin only contraceptive is recommended, and the risk of pregnancy in breastfeeding women is around 4% per year. Contraception counseling should be ideally begin in the antenatal period. Permanent and LARC are most effective and having 80% less chances of repeat delivery within next 27 months. So mini lap after vaginal delivery can be done within 24 to 48 hours and up to 6 day postpartum. So what is the duration where mini lap can be done? Mini lap can be done for 2 days till 6 days. So 2 to 6 days we can do it. Now for coitus resumption, after 2 weeks of post-delivery, coitus may be resumed based on the desire and comfort, and in 60% of the women resume sexual activity by 1 week and 80% by 4 months. So in 60%, the sexual activity is resumed after normal vaginal delivery by 1 week and in 80% by 4th month. And after 2 weeks of post-delivery, coitus may be resumed. So traditionally, the postpartum visits has been recommended after 6 weeks after delivery, and ACOG recommended an encounter, that is in person or by phone, with the maternal care provided in the first 3 weeks postpartum to address the acute issues. WHO recommend routine postpartum evaluation, that first patient you have to see the patient for at around 3 days, means 72 hours, 3 days, then 1 to 2 weeks, then 6 weeks. Thank you.